have a good group. So why don't we just get started to kind of maximize Dr. Nidey's time with us. I'm really excited to introduce Dr. Nichole Nidey, who is currently an assistant professor of maternal and child health at the University of Iowa College of Public Health. But prior to her position at the University of Iowa, she was actually here with us at Children's. So she did a postdoctoral fellowship and was an assistant professor both within the Division of Biostatistics and Epidemiology here at Cincinnati Children's. And we're super excited for her to be returning for this CCTST Grand Rounds to tell all about this really exciting and innovative use of journey mapping in community engaged research that was actually initiated during her time here at Children's and in Cincinnati. So I will just give you the floor, Nichole, and thanks so much for being willing to talk about your research. I think everyone's going to find this really, really cool.
Thank you. I'm going to actually reshare because I just realized I didn't share to optimize for sound. So hold on one moment. I'm proud of myself for recognizing that before nobody could hear a clip that I have in a little bit. Hold on. Okay. Hopefully you can see my screen again. Thank you for that introduction. I did recently learn that an Iowa team played UC for your homecoming. I will say that I'm not coming from that university in case there's any bad blood left from that game. Let me advance my slide. Perfect. So if I do my job well today, hopefully you'll walk away knowing a little bit more about why it's so important to do patient and community engaged research. And you'll be able to define what journey mapping is, specifically as it relates to patient journey mapping. And then finally, to learn a little bit of how you could potentially use this type of tool or method in your research. And so first, we're going to start with a couple of definitions from the Webster's Dictionary, just to make sure we're all kind of thinking about the same thing. And so Webster tells us that community is a group of people that are living in the same place or having a particular characteristic in common. So it looks like there's 31 of us together in this Zoom space. So right now we're a community because we have this characteristic in common that we've come together for Ground Rounds. And I'm guessing that many of us here also are really into community and patient engaged research. Next is a patient. So a patient is a person that's receiving or registered to receive medical treatments. This is also a noun. And then we have engagement. This is our first verb in these three words, and it means to establish a meaningful contact or connection with. I want to do a quick shout out for everybody to know that engagement is a verb, it's an action verb. And right now it kind of sounds buzzwordy, but it's really not a buzzword. And so as we have more calls in research to include patients and community in our work, we have to be really careful and ensure that we're including them for the right reasons and we're doing it well and trying to build up the trust that we have a lot of work to do with our communities. So why is patient and community engagement important for research specifically? And so when we engage meaningfully with patients and communities, this allows us to ensure that their priorities, their perspectives, and their needs are incorporated in the work that we're doing, hopefully doing together, which will then lead to better relevance of the work we do, improve quality. It will enhance our ability to disseminate our research as well as implement our findings. We know that we have a lot of work to do in trying to get the evidence base actually to the bedside. The amount of time it takes for that transition is far too slow. As I mentioned a little bit ago, it will help build that mutual trust. And then having patient and community engaged research really fills out that roster or that team for team science. So oftentimes when we learn about team science, we talk about multidisciplinary or transdisciplinary collaboration, but another group of people, not just one, but a group that needs to be at that table are people that have lived experience of either the exposure or the outcome or the topic that you're focusing on. And so I'm going to give you a really brief introduction to the Empower Project. This is a project that I started that Dr. Bowers alluded to when I was in Cincinnati. So the first grant that I ever got as a postdoc, I will say, is probably the most important grant that I'll ever get in my career. And it was from the CCTST. It was a small $5,000 grant, but what it did is it gave me the permission at that time that I felt I needed to do this type of work. And so prior to coming to Cincinnati, when I was doing my dissertation, I realized that the perspectives of people with lived experience of drug use and pregnancy was largely missing from research. So this was my motivation for trying to bring people together, people with that lived experience, to make sure that we're doing better work in this space. So in 2019, I started the Empower Project. And together with our stakeholders, we developed a mission, which is to meaningfully improve outcomes and options for pregnant and postpartum persons with substance use through patient-centered, co-led, and co-designed research. So when we originally started Empower, it was with 6 stakeholders in the Cincinnati or tri-state region. Since our initial funding from the CCTST, we went on to get some federal funding as well as some more internal funding, as well as funding from the Ohio Mental Health and Addiction Services group. And so this allowed us to expand our collaborative out to 7 states, and we now have 30 stakeholders in our group. And I think something that's really special about our collaborative is a majority of our stakeholders have that lived experience of substance use. So 20 out of our 30 have lived experience of substance use during pregnancy. The other groups that are represented include a lot of different types of healthcare providers that care for moms and babies, community partners, and others. And so the first year that I spent learning and listening to our stakeholders with that initial CCTST grant, I heard all of these stories, and I continue to hear these now. I feel like I've become this receptacle of stories from people who have lived experience of substance use. And I quickly realized that my training as a quantitative epidemiologist hadn't really quite prepared me for this, to do justice for what I was hearing. I was trying to figure out, how do I take these stories and have them come out as research information, as well as information that will help move people more towards this work. And so I've started to learn a lot of mixed methodology, but I also feel like it's important to hear from them themselves. And so I want to give you kind of an example of what I listen to now a couple of times a month. So we meet about 3 times a month with the Empower Project now, just so you can kind of see what I see and hear what I see. So now we're going to learn about Tara. So Tara was one of our first stakeholders in the Empower Project in 2019. And Catherine, let me know if for any reason you can't hear or see it when I hit play.
I think recovery is an endless journey of just trying to become a better person. The first time I ever went to jail, I was pregnant, and back then I was in my addiction. I was addicted to heroin, and when I went to jail, they completely detoxed me cold turkey, even though the hospital had said she needs to stay on methadone. Back then, there was a lot of stigma. Doctors would tell you, you have to get off your MAT, which is medicated assisted treatment. When I was pregnant and I was trying to get on MAT, it was really hard and wasn't taken seriously. I'd go to a hospital and they'd be like, well, we'll make you an appointment. And I need an appointment now when you're in addiction. It's not like I'm ready now. You can't put somebody off when they're full-blown addiction. They might not make it back. Many years while I was in my addiction, dealing with the healthcare system has been very trying. You don't feel like your opinion's heard. It's caused a lot of trauma in my past, trying to put you in a box. I've had times, again, when I was pregnant, I was actually in recovery with my youngest son. He's 6. And they induced my labor, then they stopped it, and the doctor just put me on the back burner and took everybody else. They just kind of didn't take me seriously. MAT is so important because it literally changed everything for me. I've went from homeless to homeowner. When I first started getting into recovery, there was only one methadone clinic in Cincinnati, and the other one was in Indiana. Suboxone wasn't there. It was just really thin, and nobody really cared. I was in a domestic violence situation, and I was in a shelter, and I was breastfeeding my newborn, and they called CPS on me because I was breastfeeding my newborn and I was on mat, and county came in and they took my kid and made me go to an inpatient rehab, even though I literally had nothing else in my system. And when I was in that rehab, they made me come off of methadone, and I promptly relapsed because I wasn't ready, and I might not ever be ready, and that's okay. Everything is changing right now around the stigma and how people are treated, and they're just now realizing that the way we were doing things isn't working. People are dying. People do need to stay on mat, and that it is a reputable source of recovery. They are more patient-centered treatments. Instead of treating the addiction, they treat the person. You're looking at other stuff like housing, clothing. Do they have transportation to get to doctor's appointments? And that's really important. It's so important to have, that harm reduction piece in the recovery system. Harm reduction is the needle exchange van, having clean cookers and cottons, even gloves, Narcan. At one point, I had saved 4 different people at McDonald's using Narcan and CPR. We want to keep the substance user alive until they can find their path to recovery. I think
So that's just one of our stakeholders in Empower. And I hear, as I mentioned before, these stories all of the time, and all of the time that I spent trying to figure out how I could show this in a bar chart, it wasn't going to work. And so this is when I found, journey mapping. And so we're going to talk a little bit about journey mapping, how it came to be, and how I've used it in my own work for the rest of the talk. So journey mapping is a tool that's used to understand and visualize experiences individuals go through or are currently going through on a journey. It's really common to use in the business world right now to understand customer experiences. So if you were to Google journey map today, you would come up with a couple of really common types of maps. One is a user experience. So maybe it would be a journey map of somebody how they interface with their cell phone, maybe trying to make it so you spend more time on your phone, spend more money on the gadgets and things like that. There could be a customer journey and a sales experience of how somebody goes on to buy something like a car, as the example that we have next. So I have 2 examples of what kind of classic journey maps look like. So this is a customer journey map for a character named Emotional Eric. I didn't name him. This is just how it came. And Eric's trying to buy a new car. And this is a journey map for when he first started thinking about getting that car to when he put an offer on a car. And something that's really classic with journey maps you'll see in this picture is it's very longitudinal, right? Like on the left, you can see at first he started to consider getting a car, started seeing ads. And then on the far right is when he actually made the offer on the car to get his new car. On the bottom of the line, you can kind of see where it's trying to depict his emotions. When the bumps get high, he's happy. And then you have these dips when things get kind of hard. And so this map does a really good job of kind of showing Eric's emotional state as he goes through the process, but also like all the different touch points. This next map I really like because it's of a museum, and I enjoy museums a lot, and it's made by the Smithsonian, and it's looking at a summary of visitor moments at their South Mall. And so again, like the last map, it's very longitudinal. It starts with at the bottom, you can kind of see it says, consider going. And so we can see the different touch points and the different activities an individual does to be able to get to that museum all the way through when they get back home again. The map also does a really nice job of showing how they kind of navigate within the museum or the galleries. And this type of map could be really helpful for the museum for planning to figure out maybe visitor flow, trying to get more people to come, maybe having a better experience there. And so these are traditionally what these maps have been used for, but generally they're used to try to understand how people navigate through really complex things. And so recently, there's been this extension of journey mapping to patient mapping. Recently is a very relative term. And so quickly last night, I looked on PubMed to see what type of research has been published using the word patient journey map. There's only about 200 articles that came up in my search. And I think the first one was from 1998, but really that kind of increase in publications has really been in the last couple of years. So when somebody will extend journey mapping to kind of look at the experiences of patients, they're really focused on a progression through a disease. So you may see at a time that somebody gets a cancer diagnosis and you'll see their experiences until they get treatment. You may also see maps that are focused on barriers and facilitators of care, including their experiences, specifically experiences interacting with the healthcare system and the providers, as well as a focus on outcomes. There are a lot of reasons to patient journey map. I'm just going to name a couple. So one is they allow you to really learn about the lived experience of a specific group of people. And it's been recommended in the literature that it's a really great method to learn about lived experiences of people who have been historically marginalized and stigmatized. They're also really good for us to try to figure out the dynamic relationship between service organizations and patients. And then finally, to understand how to improve the quality of care for our patients through their lens. So the methodology for patient journey mapping is pretty blurry. There's no standard right now. So when there was recently a systematic review that came out, and it really found that there's a lot of variability in how people are doing the mapping itself, how they collect the data to create the maps, and then how they show the data. So the graphic, the map that you would see, and I'll show you a couple more examples of mine in a few minutes. But as an example of that variability, there's a lot of different ways to collect the data. So for some, it's based on interviews. So this could be one-on-one interviews or focus groups. It could also be based on surveys. They could be surveys that were designed specifically to do the map, or it could be maybe customer or patient satisfaction surveys. Other maps are based on tracking movement, so how people move across the hospital. So this is probably similar to that museum map that I showed you a moment ago. And then other times people aren't collecting any primary data. It's really secondary analysis of existing things such as case notes or electronic healthcare records. And so they're really not having any interaction with the patient. Regardless of the type of map, while there is a lot of variability, there are some similarities between customer, patient, user experience maps. Oftentimes there's a who, so that person we're focused on. So with the car buying experience, the who was focused on emotional Eric, the museum was a museum visitor. So there's generally a who in a scenario of what they're doing and the stages that they go through in their actions, as well as their emotions and thoughts. And then also a focus on identifying opportunities for improvement. So in my work, I'm really interested in learning about the healthcare experiences of pregnant people with substance use. And so I've done work using survey data from the CDC, healthcare data. And so one of the papers I published with Dr. Bowers was using CDC data from the PRAMs, and we found that pregnant people with substance use were half as likely as their peers to get access to prenatal and postpartum care. And so that study showed us that there is this disparity in care, but it didn't really tell us why. It didn't tell us how we can fix it. And we weren't really sure what the priorities were of this patient population or where to intervene. So I've had a lot of people ask me how I've made the maps for Empower projects. So this is what I think I'm just calling the Empower methods that we've used. And it's our staging that we've done. So the first thing that we did when we started mapping is I found my co-pilots. It's a process, it's a method that you can't really do by yourself. And so what we did for our work is first I found a professional facilitator who's trained in working with trauma, stories with a lot of trauma. So it was really trauma informed because we knew that that was going to come out of these stories based on the work that I've done with these stakeholders. Next, we needed an artist because I definitely could not draw the map in an engaging way that would move anybody. And then also, because of the topics we focused on, we also had a psychologist on our team. So I'm really lucky that one of my co-pilots at Cincinnati Children's was Stephanie Weber. She's in developmental and behavioral pediatrics. So she's a psychologist, and she attended all of our interviews with our stakeholders. And she was there in case that they needed some help or needed somebody to talk to during the interview process or after. It's also really important too to note that she had an engagement and a connection with them before we did this mapping as being a part of the Empower project. So step one is finding the right co-pilots for your team. Next is the prep work. And so we prepped the facilitator. I gave her, I think, a list of 100 questions to ask in case nobody was talking, because that was always my fear. We never really needed to use that. People did a great job sharing with this work. But then we also prepped our interviewee. And so I didn't give the interviewee those 100 questions. We just told them these are the main topic areas we're going to talk about. We're going to ask you about what it was like when you found out you were pregnant. What was it like when you tried to find a healthcare provider for prenatal care, substance use treatment, and community resources, things like that. So we prepped them in advance. Then we did our interview. Our interview was 2 hours. And because we were in the context of COVID at this time, it was all done through Zoom. And so what we did is we had our artist share her screen, and then our facilitator, you could see her on screen, and then the rest of us as well. Something that I haven't really seen talked a lot about in the literature, but I think was really important for the work that we did, is we had live creation of the map. And so as our participant told us about their experiences, our artist drew their experiences in real time. And I think this is really important because sometimes we'll take notes, and I'll take notes from my lens of what somebody tells me. And then if I go then on my own to put it in a map or tell the artist to put it in the map, I may not have interpreted what that person meant correctly. And so we encouraged our interviewee to stop us and say, hey, the way that you drew that, the words that you said are not representative of what I meant. We also asked them to look at the map and say, if this isn't telling your story, to let us know. If we need to add more information, take things out. So it really gave them the opportunity to be in the driver's seat. And then after creating the map, it's really important to share that map with the interviewee back. If you need to ask me a question in the Q&A and you can't think of one, please ask me how our interviewees have used these maps after they've gotten them from us. So these are our steps. It seems simple, but there's a lot of work that's gone into it. And I would say we had six interviewees, 2 hours each. That was 12 hours alone of just listening. And every time I do this process, I learn 100 new things. And then my list for potential research questions just kind of grows in a way that feels sometimes unmanageable. So this is our first map. This is a personal journey map. And as you look at it, you may think that it looks like there's a lot going on, and that's intentional. And so because there was a lot going on at the time that this individual found out that they were pregnant, and as they went through the process of pregnancy, you'll also notice that it's not linear, because it didn't really feel like there was a start and end. A lot of these things just kind of pervaded through all of their steps. And so we're going to kind of pull out different pieces of this map next to show you how I've kind of used this to think about work. First is you see a lot of examples of stigma in this map. So this helps me think about the different experiences they have. We see the use of stigmatizing language for the participant to describe themselves. So this potentially is evidence of internalized stigma. We also see where the individual says addiction. So you have that A there. It's like a scarlet letter. I have a felony on my record. You can see the community-based stigma that affects this individual. And then on the far right, where she says, it feels like nobody trusts me, nobody believes me. This is enacted stigma, is also defined as discrimination within the birthing setting. And then finally, this individual calls out the stigma and says, look at me and not the stigma. And so we really see that stigma is an important part of the experiences individuals have. And again, kind of going back to, I do a lot of work with electronic healthcare data, but this is the type of information that you wouldn't really be able to find very well there. Next, The other part that we found is lots of experiences of trauma historically as well as currently. And so when you look at the gravestone on the left, you can see that this individual is talking about all the different people that are important to them in their life that had died. They had said most of the people I knew in my 20s are dead because of overdosing. You can see that this person doesn't have their mother or father either, and nor do their children have their mother or father. We can also see in the image with the arm going through the wheels that they feel like the system has failed them. So this does point out some system failures, but this individual had also said that they have a lot of trauma and PTSD symptoms from their deliveries. And the reason why I pulled out that I have 7 kids, 5 are born exposed, is because if each delivery was traumatic, you have this repeated traumatic experience in the hospital at least 5 different times. And now a really important part too is the priorities, or places where we can think about intervening. These are the opportunities that we can take to improve experiences of this population. And so right away, you can see peer support in the middle. This individual said peer support, it could be a game changer. And then also along with it, they had said, my favorite counselor had lived experience himself. This individual used stigmatizing language, and that's okay. But oftentimes when I try to describe people with substance use, I try to use the person first language. So, but what we can see here is they're telling us that they really want somebody within the care setting that has lived experience. They also are saying that we need to have empathetic and respectful care. And again, to look at them and not the stigma. Next, in the far right, you see this little baby, and it has a couple of things written there. One says, let sleeping babies sleep, score the baby in the room. And so at this time, this individual was telling us all of these things that they were asking for to support the care of her newborn, and she wasn't being listened to. So the message of please listen to me, let me decide what's going on with my baby was a pretty clear finding in this person's story. And then finally at the bottom with the light bulb where it says, this makes me shine. So this individual was talking about how they really feel like they have something to offer. They want to share what they've learned to ensure that people that come behind them don't have the type of experiences they have. So there's a really cool area of research if you're looking for something to look up later, and it's focused on mattering. So there's a lot of work on resilience and trauma, but another kind of piece of that is there's been some studies that have found that if an individual feels like they matter, they have improvement in some of their mental health symptoms and general well-being. And I think this would be a really cool place to better understand how it relates to substance use and recovery. So after we did 6 of those maps, then we summarized them all together. And this is the map that you see here. It has a little bit more of that linear flair. You can see at the start with where it says my life was in chaos, and we can see a lot of the experiences our stakeholders had leading all the way to when the baby was born. But really importantly, it shows us that there's system level things that we need to change. We can see the stress that these individuals go through. And it really kind of helps us think about research questions and interventions that we can do to better support these families. This is another map. And this map is focused on recognizing the trauma and stigma in the patient journey. And so what we did here is first we tried to identify what the pain points were. So this is in red. So our stakeholders had said what makes it really difficult to get substance use treatment during pregnancy is related to trauma. And so somebody had told us when we were doing this session that it's never like it's never easy to go. We feel like we're carrying this really heavy bag that's trudging behind us, which is why you see that full backpack with stuff hanging out. So it's really hard just to kind of seek help. And seeking help is also really difficult. One of our stakeholders had said they'd never felt safe asking for help before. So this was really hard to do. But once they got in and they asked for help, navigating was really hard. And they would come up with a lot of providers that didn't quite know a lot about substance use. And so they felt like the education of healthcare providers was pretty low as it related to pregnancy and substance use. And then finally, once they kind of got through this maze and they jumped through the hoops to get to treatment, they felt like there was not individual treatment plans, and they felt like the treatment plans weren't working for them. And importantly, they had said that the stigma of substance use really kind of overshadowed every step of their journey. The green part are the places where our stakeholders had said, this is what you can do to make it better. And if you do all of these things in green, this will roll out the red carpet for us to have better patient-centered care, which is why you see that red carpet in the bottom. So again, this goes back to trauma-informed care, but it's really important to have it at all touch points at the patient's journey. Having better resource navigation tools. And so one of our stakeholders had said that they found out they were pregnant when they had to go to the ER for something else. And when they got to the ER, they found out they were pregnant. So somebody gave them this list of places they could call for substance use treatment. They called all 10 places on that list, and none of those places would accept a pregnant person. And so these are really sometimes simple things we can do to make it better for our community members. And then education of trying to figure out a way that we can ensure that healthcare staff know about substance use and trauma, and especially around the timing of pregnancy. And then finally, having a better culture of nurturing. So one of our stakeholders had said, this has always kind of resonated with me during this process, is I was at a time when all I needed to be nurtured, but I just got tested over and over again. So we really need to figure out a way to develop a culture of nurturing. And then at the bottom, there's more ideas that they had of how we can improve experiences for them. But I kind of want to go back to in the beginning, I pointed out a lot of journey maps are linear, especially in the customer service field. But when we tried to do that, it felt really impossible for us because all of our stakeholders had said, we're on this journey forever of recovery. It feels like it's never ending. And so that's why you see this track at the bottom that looks like a walking path, but it's actually an infinity symbol. My kids would call that an Easter egg in their video games. So that's our Easter egg in this journey map. And so in conclusion, because I'm hoping to have enough time for questions, is for journey mapping and research, it really gives us this new understanding. It highlights to us gaps in services, research, and resources that we need to think about to improve care. It shows where interventions are needed. It gives that overview of the entire journey, not just snippets. It's a very patient-centered approach. And I think it's even more patient-centered or community-centered if you're focused on community members who aren't patients, is really listening to the stories of these stakeholders, allowing to see them, how the map is being drawn so they have the ability to edit it and make sure it represents them. And then it creates a really cool tool and image that can be used in a lot of ways. So I think this map is a research product within itself, but it also I've used it when I've gone to community meetings to help people understand the experiences of these individuals. It helps build advocacy, and it's also been used in a lot of different educational ways to help better understand this specific population. I'm not going to end with a big summary slide. Instead, I'm going to end with a homework slide for all of you. So in the state of Ohio, the leading cause of maternal death is overdose. When I was in Cincinnati, I used the data from the Maternal Infant Data Hub to see who was dying and what were they dying from. 80% of people who died in the first year after having a baby had substance use during pregnancy. The leading cause of death was overdose. And so when you heard Tara's story, she had said that she had Narcan for people in a McDonald's. That was a McDonald's that's really close to Cincinnati Children's Hospital. And so my goal is to increase the amount of people who carry Narcan. So it's really easy. If you haven't figured out how to get it yet, you can just Google it, get free Narcan in Ohio. That's what I did. And then I ended up going to the next distro website and I had it mailed to my door within a week. You also can now get it over the counter. So the FDA approved Narcan as an over-the-counter medication in 2023. I've also bought Narcan from the pharmacy at Target. And then finally, you can see it on Amazon now too. So there's a lot of different ways that you can get Narcan. And so this is one really great way that you can support your community. And then with that, I can stop and take questions.